So today's lecture is on first part of the pharmacokinetic, that is the absorption. So as I have taught you till now, that pharmacokinetics deals with the effect of body on the drug. So what the body is going to do when we take a drug, when we are going to administer a drug to our body, what the body does to the drug, that is known as the pharmacokinetics. So there are the different steps in the pharmacokinetics are the absorption, distribution, metabolism, and excretion. And today I'm going to talk about the absorption, what happens, how the drug is absorbed, what are the factors which are going to affect this absorption of a drug. So at the end of today's lecture, you will be able to understand how a solute is transported across the biological membrane, what is absorption, what is bioavailability, what is the difference between bioavailability and the bioequivalence, and then how we can increase, or what are the factors which are going to influence the absorption of a drug. So all this I am going to talk today. So the different pharmacokinetic parameters which or the phases which a drug has to undergo is, the first, the drug is absorbed, and from the dosage form the drug mixes with the GI secretions and a solution of drug is formed. Then this solute is absorbed either from the gastric mucosa or from the intestine. It gets absorbed, and then the free drug reaches into the systemic circulation. So it is actually the free drug which produces the effect. So here the absorption phase ends. Then through the systemic circulation, the drug gets distributed in the body, and this free drug can either bind with the plasma proteins and remain there for a longer duration, or the free drug then goes to the site of action where it binds to the different receptors or transporters or channels, and then they produce the effect, and then return back to the systemic circulation. The free drug can go to the storage tissues where they get bind to the different tissues as per their affinity and remain there for a longer duration, and then they are slowly released back into the circulation, and then are going to produce the effect also. And then through the systemic circulation, the drug gets transported to the various organs such as liver, kidney, etc. And there the majority of the drug they gets biotransformed, and these biotransformed drugs, then metabolites are formed from these drugs, and they are excreted out, or the free drug is excreted out through the kidney, or through the intestine from the body. And that's how the life cycle of a drug is, right from the intake to its absorption, distribution, and then the drug gets excreted either in urine, bile, feces, sweat, or saliva. So that completes the whole cycle of a drug, or the different steps which a drug undergoes through our body. So the various, if we are taking a drug orally or is being administered rectally, then what happens? Then the drug comes into the GIT and through the portal circulation reaches the liver. The drug can be excreted as such from in the feces, or the drug from the liver, drug gets metabolized, and through the kidney it is excreted, or from the liver the drug comes into the circulation and reaches into the plasma and gets distributed to the various body systems, and from there they are going to produce the effect. Or the drug can be recirculated by secretion into the bile, and then again coming into the gut. The drug from the topical application from the skin comes to the plasma. The intravenous drug directly reaches into the plasma. Then the intramuscular drug administration, the drug from the muscle reaches to the plasma. Then the intrathecal through the CSF then to the brain, and then the drug reaches to the plasma. Or inhalational, the drug from the lung gets uh, absorbed and reaches to the plasma. And the drug from the lungs can also be directly move out through the expired air. And from the plasma, the drug then gets distributed to all these body organ system. In the in the pregnant females, it is the placenta through which the drug reaches to the fetus, or can get from the plasma. The drug can go to the kidney and excreted in urine, or can go to the various glands such as sweat gland or the breast, and then excreted in the milk and the sweat. So the various excretory products of the drug can be excreted through the urine, feces, milk or sweat, or the exhaled gas. That is how the drug comes out from the body. So coming to the biological membrane, which the drug has to cross before going absorption, you all know that the biological membrane is a lipid bilayer in which the hydrophilic site is outside and the hydrophobic ones are the inside. And then there are certain proteins known as the extrinsic proteins or the intrinsic protein which traverse the cellular biological membrane. So the hydrophobic molecules, they can easily cross this biological membrane since it is a lipid bilayer. And the small uncharged or the polar molecules also can easily cross this biological membrane. But the larger polar molecules or the highly ionized molecules, they are not easily transported across this biological membrane. So how these molecules get transported? That the basic biotransportation across the biological membrane of these various drugs occurs by either from the diffusion or the active transport. In the diffusion, we have the drug gets distributed from the from the higher concentration to the lower concentration. That is, they depend on the concentration gradient. And in the passive diffusion, no energy is required or the other protein is required. While the facilitated diffusion, there is no requirement of energy and the diffusion is gradient based, but carrier protein is required. So these ion channels or the carrier proteins, they are required for transporting this molecule across the biological membrane. Then the active transport, they require the energy for the transportation. It can be primary active or the secondary active transportation. The primary active transportation, where in both these active transportation, the basic transportation is occurring from a lower concentration to a higher concentration. That is against the concentration gradient. So in the primary active, the energy is provided from the ATP, and there is requirement of a protein molecule. The ATP binds over here, and then the molecule is transported across the biological membrane. While in the secondary active transport, what happens? The gradient of one molecule or one substance drives the passage of the other molecule. There is no requirement of ATP, but there is requirement of the carrier protein, and it is the movement of one molecule or the substance which moves the other molecule. So the movement of both the molecules can be in the same direction, that is the symport, or in the opposite direction, that is the antipode. That means the second molecule is moving opposite to that of the first molecule, that is antipode. So there are two types of transporters across the biological membrane. One is the ATP binding cassette or the ABC superfamily, or it is known as the primary active transport. The glycoprotein present in the biological membrane is the belongs to this ABC class of transporters. They are present in the intestinal mucosa, renal tubules, and the blood-brain barrier. And their main role is efflux of solutes from the cytoplasm, and thereby they help in the detoxification. The other type of the transporter are the SLC transporter or the solute carrier transporters. They are helpful in the secondary active transport or the secondary or the passive facilitated diffusion. They are the organic anion transporter proteins, the organic cation transporter proteins, and they are expressed mainly in the liver and the renal tubule. and they help in the metabolism and excretion of the drug. So these are the two types or different types of the transporters. So if you see this diagram, so the first A, here the molecule is a poorly diffusible substrate which is moving from its higher gradient to the lower gradient with the help of a transporter, that is a SLC transporter. So what type of transport is this? This is a facilitated diffusion. Okay, there is requirement of a protein, and the gradient is from a higher concentration to the lower concentration. Then if we see this B, here what happens, the transportation of the molecule of the substrate is being done from the lower concentration to the higher concentration. There is requirement of ATP and a transporter protein. So this is a type of primary active transport which is occurring with the help of ABC type of transporter. Then if we look at C, this is C. So here what we see that the substrate A, that is moving from a lower concentration to a higher concentration, there is a requirement of transport protein, and this movement of substrate A from a lower to higher concentration moves substrate B from its higher concentration with along with the substrate A. That means both the substrate are moving in the same direction. That means this is a type of syn-port. This is syn-port. While if we see D, here what is happening, that substrate A is moving from lower concentration to higher concentration, and this gradient drives the substrate B from in a opposite direction to that of the substrate A. That means both substrate A and B are moving in opposite direction. That means this is a type of antiport. Then one more method of transportation is pinocytosis or the cell drinking. It involves the invagination of a part of the cell membrane and trapping within cells of a small vesicle containing extracellular constituents. So vesicle contents are then released within the cells or extruded from the other side. They come inside the cell and then are extruded out from the other side of the cell. So this is important for the transport of some macromolecules such as insulin through the blood-brain barrier. So important point to remember from here, it is that the drugs which are unionized, having low polarity and higher lipid solubility are easily transported across the biological membrane. They are easily permeated through these membranes. While drugs, if we see those drugs which are ionized, having high polarity and lower lipid solubility are difficult to permeate across the biological membrane. So the unionized, highly polar and the lower lipid soluble drugs are difficult to be transported across the biological membrane. So coming to the pH effect of this transportation, that most of the drugs which we are consuming are either weak acids or weak bases. So ionization of drugs, they markedly reduce their ability to permeate through this biological membrane. And the degree of ionization of drug is determined by the surrounding pH and their pKa value. I will tell what this pKa value is. That the weak acid, they are more ionized in the basic media, and the vice versa is for the weak bases. Weak bases are more ionized in the acidic media. So one equation is very important, that pH is equal to pKa plus log of the unionized, that divided by the ionized divided by the unionized drug. So this pKa is the negative log of acid dissociation constant, and based on this equation we derive very important factors which influence the absorption of the drug. So if we see what this pH and ionization has to do, is that if in that same formula, when the pH and the pKa are equal, okay, that means pH minus pKa is 0. So what will be the degree of ionization? Then the degree of ionization will be 1. So 1 is to 1, because log of 1 is 0. So then the pH becomes equal to pKa, or pH minus pKa is equal to 0. From this we come to know that pKa is equivalent to the pH when the ionization of a drug is 50%, or 50% of the drug is ionized. That means the ratio of unionized to the ionized drug is 1 is to 1, 50 is to 50. So if in the case of the weak acids, what happens that as we increase the pH by 1, that means pH minus pK is 1, that means pH is 1 increased, then what will happen is that the ionization is increased by 10 times. That means log of 1 is log of 10 is 1. That means by increasing the pH by 1, there will be 10 times ionization. That means the unionized will become 9 and ionized will become 91 from the same formula. And vice versa, if we decrease the pH by 1, minus 1, then the unionized will become 91 and the ionized will become 9. That means in the more acidic pH, the weak acids less will be less ionized and more will be unionized. So from this we derive that when we are giving a weak acid, if a drug is a weak acid, that means it will be more unionized in the acidic media and will be more ionized in the basic media. So if we are administering a drug, and so in which part of the GIT do you think the drug will be more unionized? It will be the gastric pH. There, the drug will be less ionized, or more of the unionized form will be there. So the absorption of the weak acids will occur more in the gastric pH, or from the stomach, the absorption of the acidic drugs, weak acid drugs will be more, because they will be less ionized. So the absorption will be more, as I have told you earlier also, that the less ionized drugs are more absorbed. So that is the implication of this calculation or this formula, that acidic drugs such as aspirin, they are absorbed largely unionized in the stomach, because in the acidic pH, the weak acids will be lesser ionized and absorbed faster, while the basic drugs such as atropine are absorbed faster in the intestine, where the pH is more basic. So basic drugs absorbed in the basic media, that is intestine. Acidic drugs are absorbed more in the acidic pH, that is the stomach. Another important implication of this effect is that of ion trapping. Suppose we have taken a, okay, can we take this question? Somebody has raised hand. So we will take this question in the later on, or through the WhatsApp chat also. So you can write down your queries and later on we will address it. Suppose a drug is being taken and it is a weak acid. So it will be more unionized in the acidic pH. Okay. And so the drug will be easily absorbed. Okay. So the drug will be easily absorbed through the biological membrane and will come inside the cell. This is the intracellular part, okay, in the gastric mucosa, suppose. And there we know that the intracellular pH is basic. So the pH is somewhat basic. So what will happen in the basic media? This drug will undergo ionization and more of the ionized drug will be accumulated. And once the drug gets ionized, it cannot cross back through this biological membrane, because the ionized drugs are less transported across the biological membrane. So what will happen ultimately? The drug will remain inside this cell in this basic media. So this leads to ion trapping, or the drug gets accumulated inside the cell. This concept is known as ion trapping. So acidic drugs, and one more implication of this important finding is that the acidic drugs are excreted faster in the alkaline urine. So what will happen that when we are taking certain acidic drugs, and if we are going to alkalinize the urine by taking urine alkalinizer, what will happen? The acidic drugs will be more unionized. So the reabsorption of these drugs will not occur. Okay, so they will be excreted out in the urine. And similarly, if we are taking a basic drug and it reaches into the renal tubules, okay, so when it is moving in the loop, when it is moving in the nephron, so what happens when we are doing the drug? We are acidifying the urine. So in that acidic media of the urine, this basic drug will be more in the ionized form. And I have told you that ionized drugs are less absorbed, or less they have less chance to cross the biological membrane, so they will be excreted faster in the urine. So we take the urinary acidifiers in case of toxicity of these drugs, basic drugs. So this concept is used for the toxicity of acidic and the basic drugs, and these urinary alkalinizer or the urinary acidifiers are given based on the drug, so as to increase the excretion of these drugs from the body or through the urine. So next, one more method of transportation across the biological membrane is that of the passage of drugs, that is filtration. This method is filtration. So I am talking about the filtration. Please wait for a minute. So filtration, there is happens is there is passage of the drug through the aqueous pores in the membrane or through the paracellular spaces. There are paracellular spaces, and the drug moves out through these. So lipid insoluble drugs can cross if their molecular size is small. So these pores are there. Their size is small, so the small molecules can easily cross. Majority of the intestinal mucosa and RBC has small pores, and drug cannot cross, so they have tight junction. But the capillaries have large paracellular spaces, and most drugs can be filtered through this. So through these paracellular spaces, filtration occurs. So filtration is movement of the molecule across the biological membrane through the aqueous pores or the paracellular spaces. And if we see the brain capillaries, so we know that there is a blood-brain barrier. Normal capillaries, they have a large paracellular spaces through which both the lipid-soluble and the insoluble drugs can easily cross. But in the brain capillaries, if we see, there are tight junctions among the endothelial cells, and there is also the a membrane type of formation of the glial cell processes or the choroidal epithelium. So only the lipid soluble drugs or the non-polar drugs can easily cross over here, but the lipid insoluble drugs are difficult to cross this. So that is the blood-brain barrier, which allows only the lipid soluble drugs to cross through it. So coming to the next part, that is the concentration. We know that concentration is amount of the drug divided by the volume. And if we see the plasma volume, the volume of in which the drug distributes is the volume of the blood is 5 liters. Plasma volume is blood volume minus the blood cells. It is around 2.5 liter. And the serum volume is plasma volume minus the clotting factors. So if we want to know the concentration of a drug, and we can consider that 100% of a drug is absorbed, suppose a drug X 25 milligram is given to a patient for pain relief. So what is its plasma concentration? Concentration will become 25 divided by the plasma volume, that is 2.5 liters. So the concentration will become to 10 milligram per liter. That is the plasma concentration of the drug. So then absorption is the movement of a drug into the systemic circulation, that is from the site of application the drug is reaching to the systemic circulation. The drugs which are absorbed, administered orally from, from the GI tract, the drugs, a part of the drug can be excreted into the feces. The majority part gets absorbed, and in the gut wall also some part of the drug gets metabolized. So the rest majority gets absorbed and through the portal circulation reaches the liver, where the first pass metabolism occur, or the a part of the drug gets metabolized and gets excreted through the kidney or through the feces, and the rest of the drug comes into systemic circulation, and that is the bioavailability. That means the amount of the fraction of the actually administered drug that reaches to the systemic circulation, that is the bioavailability, that is available for the action or production of the action of the drug. So bioavailability is a very important concept. Many times you will have questions on bioavailability, that it is the rate and extent of absorption of a drug which is determined from the plasma concentration time curve in blood. And it is the fraction of the drug that reaches systemic circulation in the unchanged form. That means if we are administering a drug by IV route, that means 100%. If we are administering 10 milligram of a drug by IV route, that means 10 milligram is directly being deposited into the systemic circulation. So the bioavailability with the IV drug is 100%. But it is lower for the orally ingested drugs, like I have shown in the previous diagram also. There are various places, the gut wall, the liver, etc. Through the feces, the drug gets metabolized or excreted out. So there can be incomplete absorption, as I have told, or the first pass metabolism. So the oral bioavailability of a drug by oral route is never 100%. Whatsoever we are administering, we are get the amount which reaches to the systemic circulation is a bit low. So what is the significance is that of the low safety margin drugs. So if we are administering a low safety margin drug by IV route, then we have to be very cautious that the 100% of the drug is reaching. And if a drug is being given orally, we have to give it in a higher dose. So we cannot give the exact oral dose by IV route. We have to lower the dose. We have to keep that in mind. But this thing becomes important for more for the drugs which have narrow safety margin. That means a small bit of increase in the amount of the bioavailability will cause toxicity. So bioavailability is determined by the plasma concentration time graph. So the number one graph, that is from here to here, which is coming on the top, is that by while the drug is being administered by IV route. So the 100% in the zero time reaches the systemic circulation, that the plasma concentration is the maximum. Then the drug gets distributed, metabolized, and excreted, and with time, this graph will come down. And if we are giving a drug orally, what happens at the zero time? There is no, and slowly drug gets absorbed till it reaches a peak plasma concentration, and then the drug gets metabolized, excreted, and then slowly it comes down. So this is, and so if we have to calculate the bioavailability, it will be the area under curve by oral divided by area under curve by IV route into 100%. That will give the bioavailability. So in the same, the drug A and B both are having equal area under curve, but only A is going to produce the effect, because the therapeutic concentration which is required to produce the effect is being reached only by A, not by B or the C, and the C is having lower bioavailability as compared to A and B. Okay, so it is also important that it depends on the plasma concentration also to produce a effect. So this is what I have told you earlier also. When we take a drug orally, so the peak of this plateau is when the absorption is equivalent to distribution, metabolism plus excretion, and as it gets lower to these sum, then the plasma concentration will slowly fall down. So in this graph also, we can see that graph with the red line. is the drug is for the drug which can be taken. Okay, the lower graph, since the minimum therapeutic level is not being reached from this graph, we can tell that this lower drug is not going to produce the effect. And then we have a upper limit also, that is the maximum tolerated level, after which we will be having toxicity. So this upward graph, we are having the levels, plasma concentration of the drug, which are reaching beyond the maximum tolerated levels. So that this drug is going to produce toxicity also. So which drug we are going to use is that of the this middle one. So then is one very important terminology is bioequivalence. That means it is a comparison of two different brand products of the same drug with a set of established standards. That means two drugs are said to be bioequivalent when the bioavailability of these two products is in between 80 to 125%. That means they are their bioavailability is somewhat in between 80 to 125%. And one very classical example of the need of these bioequivalent studies was because phenytoin, some patients were being given with the Delentine. They were this phenytoin is used for controlling seizures or the epilepsy. So they were controlled by giving Delentine. So, but this was containing a different salt of phenytoin, and eptoin contained a different salt of phenytoin. The release of phenytoin from this formulation was the bioavailability was lower with the eptoin. So what happened? The patients who were controlled with this earlier product, when they were given the second product, what happened? They had seizures. So then the need of these bioequivalent studies came into existence. That means two things which are looking identical may not be similar, because since they are being produced, same salt, same drug is being produced by two manufacturers, so the adjuvants or the other ingredients which are there in the drug, they can vary. We are using a different salt of phenytoin, so their bioavailability can vary. So that happened with phenytoin. So we have to do this bioequivalence study, and we have to select those drugs only which have the bioavailability somewhat from 80 to 125%. That means they are somewhat similar. Then the factors which are going to affect the absorption is how the absorption will be affected. Is first is the lipid solubility. More the lipid soluble, more will be the absorption. Molecular weight, small molecular weight substances are more absorbed, and the polarity, less polar, will be more absorbed. Then the blood flow to the absorption site. More is the blood flow, more is the rate of absorption. Total surface area available for absorption. More is the surface, more will be the absorption. Contact time at the absorption site. More is the contact time, more will be the absorption. Affinity, more is the affinity, more will be the drug will remain bind to that tissue. And then route of administration, how we are going to administer. So coming to the different route, what will happen that when we are giving a drug topically, the lipid soluble drugs are more absorbed and they penetrate the skin, such as glyceryl trinitrate, hyoscine, nicotine, testosterone. Organophosphate compounds, because of their high uh, solubility, are producing more systemic toxicity. And then cornea is permeable to the lipid soluble drugs, so more lipid soluble drugs are absorbed through the cornea. Mucous membrane of mouth, rectum, and vagina, they are permeable to the lipophilic drugs. So the more the lipophilic drugs, they are absorbed. And when we are giving a drug by the subcutaneous or the intramuscular route, so the drug pass through the large paracellular pores of the capillaries, and it is exercise and heat will increase the absorption, and we rub it with the absorption will increase. And if we are giving adrenaline, what adrenaline does, it causes vasoconstriction, so the systemic movement from the site will decrease, so the absorption will be lower. And when we are giving a drug orally, so the what are the factors which are going? Physical state, lipid solubility, and then the particle size of the drug, disintegration and dissolution time. More is the less is the disintegration and dissolution time, more faster will be the absorption. Then the formulation, what slow release preparation are there, or the quick release preparation are there. Based on that, also the absorption. Then the physiological factors such as ionization, I have already discussed. pH effect, I have discussed. Presence of food. Food can delay the GI motility, so the absorption will also decrease. And the presence of other substances, certain substances increase the absorption, certain substances they decrease the absorption. So, and first pass metabolism, I have already discussed that before reaching the systemic circulation, certain part of the drug gets metabolized when we are taking it orally in the liver or the intestine. As a result, the systemic circulation will get a lesser amount of the drug, and more first pass metabolism is for the drugs which are going to be absorbed from the intestine or from the stomach, and lesser for the given through the buccal or the rectal route. The buccal and the rectal route, they bypass the first pass metabolism. So what happens when we give a drug? IV has no absorption phase, and the rate of absorption is faster for the inhalational, followed by sublingual, rectal, IM, subcutaneous, transdermal. Inhalational has wider surface area, high blood flow, so the absorption is very fast. And by the different routes, the same drug is going to have its action also differently. When we give a drug by IV route, its effect is immediate. Sublingual, it takes time. Rectally, 40 to 60 minutes. So this is all. So that was all for today. And tomorrow I will talk about distribution.